The purpose of the red and green bed day is to highlight what patients might be waiting for on their journey through the hospital from their point of admission right through to their point of discharge. I would start by saying a red bed day is where a patient is receiving care that isn't progressing that patient's recovery through to their discharge, where that care could be delivered in another environment other than within an acute hospital. A green bed day is where a patient is receiving care that can only be done in hospital and is progressing that patient's care towards their discharge. Practically, to deliver the red and green bed day on a ward, you might start with having every patient marked as red, and the clinical team on that ward then have to affirm to themselves at the board round that they are converting that day from a red bed day into a green bed day.
Our red and green day journey started approximately 18 months ago. We had a visit from the emergency care intensive support team. They said, we have an issue with flow, and they said, have you heard about red and green days? We thought, well, what are these? Do we even know what a red or green day is within the hospital? Were we even aware how long we should be waiting for a certain intervention to take place? And we didn't. So we quickly got a group of people together, clinicians, nurses, ward staff, to sit and identify what our professional standards should be. In other words, what is the correct time to wait for a given intervention? 18 months down the line, red and green days are just part of our life here now. Every day on every ward, we run our board rounds in a consistent manner, and every patient on every ward is identified as either red or green.
It is not a reporting instrument. It is a tool to help clinical teams on the shop floor progress patients' care to ensure that they minimise any unnecessary waiting for such things as decisions, diagnostics. If that unnecessary waiting is identified, the team on the ward progress it to try and prevent that unnecessary waiting. They also then escalate it if they can't progress that, so the operations team know what patients are waiting for and they can assist in progressing that care.
So we have two multidisciplinary site meetings during the day, one at 10:30 in the morning and a follow-up at 2:15 in the afternoon. The discharge coordinators come to the meeting with all the red days that have been identified at the board rounds earlier on. We go through those red days with social services and community colleagues who are also at the meeting, identifying what areas we can escalate, what diagnostics need escalating. The discharge coordinators came into post when we first really started looking at the red to green process, and they link in with the clinical staff on the ward, and they come to the meetings to give the information and leave the nurses where they need to be on the wards with the patients.
We initially thought most of our delays would be external delays. What we quickly found from tracking them on a daily and a weekly basis was that we had a lot of internal things that we could sort ourselves. An example of this is where we had insufficient therapy staff helping on a ward.
In one of the red to green meetings, in the reports coming back in, it was quite obvious that there was therapy lacking in that area, and we were trying to share the staffing around, and there wasn't enough, so it was flagged up as an issue. And on the back of the needs for that ward and the red to green needs, we managed to get some staffing funded.
The red days data is entered at ward level by the discharge coordinators, and it gives us the 5 top reasons for the delay.
The point that we're in now is that we have actually sorted most of our internal issues. We now have more external issues, so we're working with our system partners across social care and across our community hospitals to embed the red and green day processes right across the wider system. One of the most amazing outcomes we've seen is that we're currently occupying 24 beds less than what we had when we set out on red to green, despite incorporating additional emergency growth. We have now eradicated flow issues from our ED department. Our number of daily discharges, certainly on the medical wards, has continued to increase. We were averaging 25 a day. We're now very capably managing 35 on average per day.
Putting red and green bed days into practice isn't just a diktat. You don't just say, right, we're going to start doing red and green bed days. The most important thing is to plan its implementation, to test how you're going to implement it, test it on 2 or 3 wards and then build it up over a number of wards. Learn from that testing and seeing how it's progressing, because the template for doing red and green bed days in each hospital will be subtly different between hospitals. You can't just transplant a red and green bed day process from one hospital to another. Very importantly, it requires executive buy-in. It needs a team of people to help develop and test it and make it work for them, being very focused on what the end result of the implementation of red and green bed days is, and that's to get rid of unnecessary waiting for patients.